Good afternoon, everybody. I would like to welcome you to this session of the International Academy of Clinical Hematology, and I would like to thank Professor Mohammed Moti and Arnon Nagler for the kind invitation. So I will be talking about maintenance therapy after allogeneic stem cell transplant in AML. So as you know, the old standard for therapy of AML is induction chemotherapy with anthracyclines and cytarabine, the famous 3+7 or variants, then 1 or 2 cycles of consolidation with high-dose RSC, and for patients achieving complete remission, depending on age, performance status, comorbidities, cytogenetic, molecular, and donor availability, either for patients with low risk of relapse and high risk of mortality from stem cell transplant, to continue with consolidation with high-dose RSC up to 4 cycles, and for patients with high risk of relapse and low risk of stem cell transplant, allotransplant is recommended, and no use of maintenance therapy as standard of care. So this is the old standard for treatment of acute myeloid leukemia. In 2017, you're aware of the European Leukemia Net recommendations on post-remission therapies in patients fit for intensive treatment. So as you can see, for a younger patient with favorable risk were recommended to receive 2 to 4 cycles of intermediate dose RSC. Patients with intermediate risk genetics, which means intermediate risk of relapse, were recommended to receive either allogeneic stem cell transplant for much related or unrelated donor, or 2 to 4 cycles of intermediate dose RSC consolidation, or high-dose therapy and autologous stem cell transplant. And finally, for patients with adverse risk genetics, allogeneic stem cell transplant from match-related or unrelated donor. For older patients, defined as patients older than 60 or 65, again, favorable risk were recommended to receive 2 to 3 cycles of intermediate dose RSC, and intermediate or adverse risk genetics, no established value of intensive consolidation therapy, and for some selected patients with low comorbidity index, you can consider allogeneic stem cell transplant or investigational therapy. So allogeneic stem cell transplant for AML in first complete remission has a potent anti-leukemic effect across cytogenetic categories. And as you can see here in this large study by Cornelissen and JCO 2012, that you have a favorable hazard ratio for allotransplant across cytogenetic categories, both for reducing the risk of relapse and for improving overall survival. So more recently, we had great development of molecular techniques, particularly for detection of minimal or measurable residual disease, what we call MRD, which can be now detected either by flow cytometry or by molecular techniques. And you can see here the Italian study and the Hovon study showing a significant the importance of MRD status in relapse-free survival and overall survival. And for example, on the left-hand side with the Italian study, patient with good karyotype or intermediate karyotype who achieved MRD negativity had an excellent relapse-free survival, and conversely, patient with good karyotype or intermediate karyotype who remained MRD positivity had a much lower relapse-free survival. So MRD in that case seems to trump the effect of the cytogenetics. So to perform allogeneic stem cell transplant, we need a donor. And now with the development of alternative donor sources, you can see here this large study of the EBMT by Vers showing overall survival of match-related donor, match-unrelated donor, and haploidentical donor, which were excellent and quite similar. Conversely, match-unrelated donor with a mismatch, 9/10 match or umbilical cord blood resulted in this study in lower overall survival. So with all these improvements in transplant techniques and supportive care and reducing non-relapse mortality, currently the relapse after transplant represents the main cause of transplant failure and death following allogeneic stem cell transplant. So you can see here the data from the CIBMTR, where the majority of patients dying beyond 100 days after transplant from matched sibling donor were dying from relapse, 57%. And even in the case of unrelated donor, still 46% of death were due to relapse of the primary disease. So the long-term paradigm that transplant is the last step of treatment and is no more holding. And currently we have development of preventive strategies, post-transplant pharmacological interventions, and others to prevent relapse after transplant. So the question is, why to prevent relapse? So we have seen together that this is the first cause of transplant failure for obvious reasons. Nobody wants to see the patients relapsing after transplant. And also because the treatment of relapse post-transplant is suboptimal for most diseases, and that the treatment of relapse post-transplant is likely more expensive than prevention for most diseases, so even from a pharmacoeconomic point of view. So the ideal maintenance agent to be used after transplant should be active against the disease and should not be too toxic, and at least not myelotoxic, with tolerable myelotoxicity to not to be toxic to the graft, can be given early after transplant. Otherwise, it's useless if you select only patients who did not relapse to give them maintenance therapy. And this maintenance agent should influence donor cells favorably and increase immunogenicity of malignant cells, so acting on the graft versus leukemia effect. So among the candidate agents, the two most frequently used currently are FLT3 inhibitors and hypomethylating agents, but also we have histone deacetylase inhibitors and multiple types of immunostimulatory agents, tumor vaccines, as well as cellular therapy, educated or not, such as CAR T cells. So I would start with a first case report. One of our patients at the American University of Beirut, 63-year-old man known to have diabetes, diagnosed in May 2012 with myelodysplastic syndrome with excess of blast, 18%, normal karyotype. The patient received 5 cycles of azacytidine. Repeat bone marrow showed dysplasia with reduced blast from 18 to 8%. So the patient underwent allogeneic stem cell transplant on January 15, 2013 from a matched sibling donor using fludarabine, bisulfa, and thymoglobulin conditioning. Day 30 evaluation showed maturing trilineage hematopoiesis with 99% donor chimerism and normal karyotype. So what would you recommend? So of course, in this webinar, we cannot have a vote, but the options are no further therapy, donor lymphocyte infusion, 5-azacytidine, and 5-azacytidine with donor lymphocyte infusion. So the patient received 5-azacytidine maintenance for 5 years. And the treatment was stopped after 5 years in May 2018, after the patient was saying that 5 years of maintenance is enough. And actually, before stopping in February 2018, bone marrow evaluation showed cellular marrow with mild erythropoiesis, no increase in blast, and 99% donor chimerism. So that was a favorable bone marrow to stop and treatment maintenance given for 5 years. Unfortunately, 4 or 5 months after stopping treatment in October 2018, bone marrow evaluation showed acute myeloid leukemia with myelodysplasia-related changes, 70% blast. The patient received cladribine, RSC, and GCSF plaque salvage on October 11, 2018, followed by a second allogeneic stem cell transplant, but unfortunately passed away a few weeks later. So we have seen that in this case that hypomethylating agent maintenance therapy with azacitidine had resulted in a long-term disease control for 5 years. I don't know whether there is a relationship between stopping treatment and relapse, the late relapse that happened after 5 years, but still we cannot exclude this possibility. And actually, from a scientific point of view, the potential effects of hypomethylating agents are to increase the expression of tumor-associated antigens, increase expression of KIR ligand on hematopoietic cells, and increase expression of minor histocompatibility antigen, and recovery of reduced expression of HLA class 1 and class 2 and 3 antigen on the tumor cells. All these biological effects will favor the graft versus leukemia effect, and similarly, the hypomethylating agents can act also on the immune cells with increased FOXP3 expression and Treg generation. So resulting with this upregulation, as you can see here in these two studies of the epigenetically silent putative GBL targets by azacitidine, the azacitidine or post-transplant epigenetic therapies may allow the dissociation of graft versus host disease from graft versus leukemia effect. So shifting the immunological effect from GVHD to GBL, which is exactly what we want. So the first study that reported efficacy or the results of hypomethylating agent was the phase 1 study by Marcos de Lima, published in Cancer in 2010. And this study showed that low dose of azacitidine, so this is 32 milligram per meter square daily for 5 days, and not the classical 75 per meter square daily for 7 days. And this low dose maintenance therapy with low dose azacitidine after allotransplant resulted in very good long-term disease control. But then we had the UK phase 1/2 RICASA trial of adding azacitidine after reduced intensity conditioning allogeneic stem cell transplant in acute myeloid leukemia and myelodysplastic syndrome. So here again, you can see that the recommended dose is 36 milligram per meter square daily for 5 days. So again, we are talking about low dose, and the immunological effect of this maintenance therapy was shown by the fact that survival according to post-transplant CD8 positive T-cell response to tumor antigens. So patients who had a good CD8 positive response had a significantly better relapse-free survival compared to patients who did not have that. So this was published by Charlie Craddock in BBMT in 2016. And then in our institution at AUB, Jean El-Sheikh published in BMT in 2017 the study on low-dose 5-azacytidine as preventive therapy for relapse of AML and MDS following allogeneic transplant. So 18 high-risk patients, 13 AML and 5 MDS. So you can see here that 28% of patients had residual disease, 2 patients had refractory acute leukemia, and the disease risk index was high or very high in 50% of patients. So we're talking about a high-risk population, and prophylactic azacitidine was given at 32 milligram per meter square per day for 5 days, started after a median of 60 days. And you can see here the 1-year disease-free survival and overall survival of 63% and 70%, which were quite encouraging in this very high-risk AML population. So that was in the transplant setting, and that was using intravenous or subcutaneous azacitidine. But you are aware of the this Quasar AML-001 study. So this is not in the transplant setting. This is a phase 3 study of oral azacitidine versus placebo as maintenance therapy in AML. So included 472 patients, 55 years or older, with a median age of 68. So with AML and CR/CRI less than 4 months, randomized to oral azacitidine or placebo for 14 days per month, consecutive days. So this is really oral maintenance and long-term maintenance. And as you can see, you have a significant advantage of oral azacitidine over placebo in not only in relapse-free survival, but also in overall survival. So this is the first time a study is showing an advantage of maintenance in AML. So I would like now to move to a second case report. Another patient from the American University of Beirut, 43-year-old male patient diagnosed in April 2012 with AML, white count 129,000, 62% blast. Karyotype was normal, FLT3-ITD positive, NPM1 negative. So the patient received 3+7 induction in May 2012, went into complete remission, then received high-dose RSC consolidation. So he then underwent a full match allogeneic stem cell transplant from his full match brother in August 2012 using fludarabine bisulfite FB4 ATG conditioning. Day 30 evaluation showed 97.5% donor chimerism. Unfortunately, the patient had a very early relapse. CBC on day 70 post-transplant showed 23% blast. So this is normally associated with dismal outcome to have a very early relapse on day 70 post-allotransplant, particularly the presence of FLT3-ITD. Bone marrow showed relapse with 30% donor chimerism. So the patient received salvage therapy with cladribine, RSC, and mitoxantrone, CLAG-M, on November 6, 2012. He went into second complete remission with 99% donor chimerism. So he then received 1 cycle of consolidation of CLAG on January 13, 2013. So, and the question is, what would you recommend between continued consolidation, donor lymphocyte infusion, Vidaza, second allo, or FLT3 inhibitors? So the patient was started on Sorafenib, 400 milligram POBID, early 2013. He is still maintained on Sorafenib until today, so more than 7 years of maintenance, repeat bone marrow evaluation since 2013 till now. Last bone marrow follow-up was in August 2018, but then we stopped doing bone marrow. We're doing chimerism on peripheral blood, and the patient is still in complete remission. No evidence of leukemia, with complete molecular remission and 99% donor chimerism. Presumably, the patient is cured, and you can see here the efficacy of Sorafenib use, this time as maintenance after second complete remission after early relapse post-allo transplant. So FLT3 mutations, FLT3 internal tandem duplication are classified in the European Leukemia Net 2017 risk stratification by genetics according to the allelic ratio and the presence or absence of NPM1 mutation. So basically, patients with low FLT3 ITD allelic ratio and NPM1 mutation are favorable. Low FLT3 ITD allelic ratio and wild type NPM1 are intermediate. High FLT3 ITD allelic ratio and mutated NPM1 are intermediate, and high FLT3 allelic ratio and wild type NPM1 are adverse. And you know that these FLT3 mutations are among the most frequent mutations in AML, representing 25 to 30% of cases. And basically, we have the most frequent mutation is the internal tandem duplication, or less frequent is point mutations D835 in the activation loop, and these results in constitutive activation of FLT3 signaling, and they have a significant impact on therapy as indication for allogeneic stem cell transplant and also for incorporating FLT3 inhibitors. So you know about this Ratify study, which is a very large phase 3 randomized placebo-controlled study, including patients with newly diagnosed AML, aged more than 18, less than 60, with activating FLT3 mutation, and patients were stratified by having either FLT3 TKD or ITD low allelic ratio or high allelic ratio, and randomized to 3+7 induction donor RSC with either midostaurin or placebo, then consolidation, high dose RSC with midostaurin and placebo, and then post-consolidation maintenance therapy with midostaurin or placebo. And these are the overall survival, not non-censored for stem cell transplant, which is the primary endpoint, and showing 22% reduced risk of death in the midostaurin arm. So the study was positive, and the midostaurin, now addition of midostaurin to induction consolidation is the standard of care in FLT3 ITD AML. And in terms of transplant, interestingly, the treatment with midostaurin increases overall survival for patients who were transplanted in allogeneic stem cell transplant and CR1. So there was no post-transplant maintenance in this study, but patients who, the blue curve are patients who received 3+7 and midostaurin and went to stem cell transplant in CR1, and the red curves are those who had placebo, and dotted curve are patients in CR1. The continuous lines are patients who were transplanted outside CR1, and you can see that transplantation in CR1 results in a significantly better survival, particularly for patients who had midostaurin induction and consolidation. So AML outcomes by FLT3-ITD mutant versus wild type. So this is coming from the large UK MRC ML10 and 12 trials published by Bob Gale in Blood 2005, showing that the presence of FLT3-ITD results in a significant increase in relapse rate and decrease overall survival. And even after transplant, in this EBMT study published by Christoph Schmidt, you can see that leukemia-free survival and overall survival from the time of allotransplant, according to the molecular subgroups, the best results are in patients with NPM1 mutated FLT3 wild type, and then the worst results are for NPM1 wild type and FLT3 mutated, both for leukemia-free survival and overall survival. So what about using sorafenib for relapse post-allo, like what we have seen here? So few small studies reported the transient efficacy of using sorafenib post-allo. However, in some of these studies, such as the German study by Metzelder, is showing that although the efficacy of sorafenib for relapse post-allo is transient for most patients, you have around 20% of patients who will be long-term survival, like the one that we have presented a few minutes ago. So then within the EBMT acute leukemia working party, we realized this registry study on 158 patients with FLT3-ITD who relapsed post-allo. 34 patients received sorafenib as part of salvage therapy, and median follow-up after relapse of a live patient was around 2 years. And you can see here that in multivariate analysis, sorafenib given for relapse as time-dependent variable resulted in a hazard ratio of 0.48 and significant p-value for overall survival. And we also realized a pair match analysis showing that 2-year overall survival improved from 14% for patients who did not receive sorafenib to 30% for patients who received sorafenib. So it works as salvage post-allo for a minority of patients, but for these patients, you can expect long-term survival. So then what about using sorafenib maintenance post-allo as prophylactic maintenance therapy? So we had this study by Chen published in BBMT 2014, dose-finding study, reporting outstanding results with 1-year progression-free survival of 85%, 1-year overall survival of 95% after transplant. And a few months later, we reported our study, the pilot study from the American University of Beirut on maintenance sorafenib in 6 patients. And you can see that for all of them, we had complete remission, continuous complete remission, even at the molecular level. The treatment was well tolerated, and some of them had really long-term disease control. For FLT3-ITD, no relapse was observed. And then we had Brunner publishing in the British Journal of Hematology in 2016, a single institution study of sorafenib post-allo, and compared to historical controls, you can see increased 2-year overall survival from 62 to 81%. And then we realized this multi-institution study between American University of Beirut, Saint Antoine Hospital in Paris, and King Faisal Specialized Hospital and Research Center in Riyadh in Saudi Arabia on 27 patients who received maintenance treatment with sorafenib, showing 2-year leukemia-free survival of 75%, 2-year overall survival of 83% after a median follow-up of 33 months. Then within the EBMT acute leukemia working party, we realized a large retrospective EBMT registry analysis to assess the predictive factors for outcome after allotransplant for FLT3-ITD, including 462 patients transplanted between 2010 and 2015. Median follow-up for survivals was 39 months. And you can see here that patients in this study, patient transplanted in first complete remission had a significantly better leukemia-free survival and overall survival as expected compared to CR2, CR3 patients and active disease. But importantly, in multivariate analysis, in vivo T-cell depletion and sorafenib post-transplant maintenance as time-dependent variable were significantly improved leukemia-free survival, overall survival, and GVHD and relapse-free survival. So this study was published in Clinical Hematology International, which is the official journal of the International Academy for Clinical Hematology. And you can see here the pair match analysis in this study showing a 2-year leukemia-free survival improving from 53.8% to 79.1%, and 2-year overall survival improving from 61 to 82.8% with sorafenib. So this study also was presented at the ASH meeting in 2018, and at the same ASH meeting we had the German randomized SORMAN trial that was presented, randomizing sorafenib 400 milligram twice daily for 24 months versus placebo after allogeneic stem cell transplant for FLT3-ITD AML. And you can see here the results, 83 patients included, and 2-year relapse-free survival improving from 53% to 85%. So these different studies, single institution, multi-institution, EBMT registry, and randomized trials are showing exactly the same data. And even the results, 53%, I mean, the same numbers of 2-year relapse-free survival and the same improvement with addition of sorafenib maintenance. And actually, in terms of mode of action, we had this very elegant work published by Matthew in Nature Medicine 2018, showing that sorafenib is not only acting on the leukemic cells, but it's promoting graft versus leukemia activity in mice and humans through interleukin-15 production in FLT3-ITD mutant leukemic patients. So sorafenib is not the only tyrosine kinase inhibitor that is being used as maintenance after allo. We have this RADIUS study for midostaurin phase 2 randomized trial of standard of care plus or minus midostaurin to prevent relapse after allotransplant. And you can see here the results showing a relative reduction in relapse of 46% with the use of maintenance midostaurin. So we need longer follow-up for this study. And we have also this study by Pearl presented at the AACR meeting in 2019. It's a non-randomized comparison after allogeneic stem cell transplant of 35 patients who continued gilteritinib that was used for treatment of relapse versus 16 patients who did not resume gilteritinib. And you can see median overall survival improving from 8 to 16 months in this study. So Different post-transplant maintenance strategies are used in acute leukemia. So you know about azacytidine, Sorafenib, also dasatinib in Philadelphia positive ALL, intrathecal cytarabine prevention. So all these preventive measures to prevent relapse. Again, Dr. El-Sheikh published in 2016 in clinical lymphoma and myeloma and leukemia the conversion of MRD positivity to MRD negativity in many patients with the use of post-transplant maintenance. So a few weeks ago, within the we published in Hematologica the EBMT acute leukemia working party position statement. So for clinical practice recommendation on hematopoietic stem cell transplant for AML with FLT3 ITD. And I would just cite a few recommendations that post-transplant maintenance therapy with a FLT3 inhibitor for patients who underwent allo stem cell transplant for FLT3 ITD AML is recommended. So there is a recommendation to use a FLT3 inhibitor except for patients with active acute GVHD, and that in the absence of an appropriate clinical trial, Sorafenib could be considered as the preferred option, and maintenance should be initiated as soon as possible. And finally, this is my last slide, summary and perspective that stem cell transplant is no longer the last step of a treatment plan, and that we have this emerging concept of a comprehensive treatment package incorporating new drugs and novel cellular and immune therapies before and after transplant. So we have multiple drugs, but the largest experience today in AML is with hypomethylating agents and FLT3 inhibitors. Post-transplant prophylactic or preemptive Sorafenib is safe with improved leukemia-free survival, overall survival, and GVHD relapse-free survival. So this is considered now as standard of care, at least as what I showed in the position statement of the acute leukemia working party of the EBMT. So we have seen together the immunomodulatory effect of Sorafenib promoting GVL effect. And we have some ongoing randomized trial, for example, the BMT-CTN 1506 multicenter randomized double-blind placebo-controlled trial of gilteritinib as post-transplant maintenance for FLT3 ITD AML in first complete remission. So the issue with this trial is whether it is considered ethical to randomize patients to placebo. 50% of patients are randomized to the placebo arm, whereas they could receive Sorafenib, which is now shown to improve leukemia-free survival and overall survival. Thank you for your attention.